The landscape of diagnosis. Today in medical imaging, more than 250 million scans can be read in 25 hours at the cost of $1,000. A live core can analyze ECGs to detect heart rhythm disorders at home. A neural network in 700,000 Mount Sinai patients from raw medical data could accurately predict the timing of the onset of schizophrenia in patients. And a convolutional neural network on 6,000 X-rays could detect hip fractures with 99% accuracy. The landscape of prediction. The Mount Sinai group studied EHRs from 1.3 million patients to predict 5 diseases with very high accuracy. And EHR data has been used to predict length of hospital stay, risk of C. diff infections, and so on. The landscape of surgery. Surgical robots today can, without human intervention, perform sutures and microsurgery in the human eye. The landscape of accessibility. Remote monitoring can possibly make some hospital rooms obsolete. And the landscape of robotics. Today, robotic exoskeletons can be used for paraplegics, and virtual hospital assistants are a possibility. The landscape of life sciences and drug discovery. Scientists are working on rewriting DNA today, and microbial therapies are discovered for deadly Clostridium infections. We can grow patient-derived brain organoids from stem cells, and immunotherapy drugs have made huge strides for cancer and autoimmunity. The landscape of drug discovery. Today, we can perform high throughput screening of drug candidates, and AI is used for target drug dose prediction, and EHR data can be used to match patients with clinical trials and for patient recruitment. In the landscape of devices, we can use brain sensing to improve sleep and performance, and wearables and monitoring devices and measurement devices are here to stay. In mental health, virtual chatbots and apps are used by patients for CBT therapy as conversational therapists, and apps are used to monitor mental health states. In the landscape of reimbursement, automation is bringing efficiencies to coding and the payment workflow. Autocorrect and prediction logic help bring efficiencies. The landscape of efficiencies. Natural language processing is being used to replace human scribes, reduce costs, and improve face-to-face communications. And medical assistants can help with triage, charting, diagnostic help, and so on. This brings us to the landscape of innovation and opportunity, the EHR backbone. The EHR as the backbone is an ecosystem for innovation. Connected devices, prediction of diagnosis, remote monitoring, virtual assistants, coding, reimbursement assistance, virtual triage, virtual patient assistance, patient matching to clinical trials are all connected to the EHR backbone. This brings me to what we are about to launch today, CharmHealth Innovate, an ecosystem for innovation. The platform to enable disruptive tech health, partnering with innovators and investors, and where ideas can be validated and scaled. A little about CharmHealth, the system. It's a Bay Area, California-based technology startup with a mission to bring efficiency and accessibility within the ambulatory medical office settings. It is a mature platform and one of the few vendors offering a complete suite of integrated software solutions to meet the needs of patients and medical practices, small and large. With an award-winning platform combined with a robust marketplace and a large API library, CharmHealth is here to support the healthcare continuum. The Charm Ambulatory Suite contains the electronic health records at the backbone and integrated telehealth, practice management, engagement with patients, medical billing, RCM, mobile health apps, and collaboration suite. The entire ecosystem has modules for patient engagement, safety management, population health, telehealth, communications, devices, billing, payment processing, automation, and personalized medicine. And a number of partners in our marketplace, a few of them listed below. So who is Charm Innovate for? Charm Innovate is for entrepreneurs to get access to technology, markets, mentors, and investment. Developers can get access to tools, sandboxes, and data to innovate. Students on the Charm platform can get started in health tech with your dream projects to change the world. Investors, network, and access to validated ideas and opportunities. And an entrepreneur's path to success with CharmHealth Innovate starts with registering at this conference to present. And with that comes access to our API, developer tools, our sandbox, and support. You get to present at this event, the CharmHealth Innovation Challenge today, work with mentors, incubators, and accessing licensing opportunities. We will help take you from growth to enterprise. So today you will get access to customers on our CharmHealth ecosystem and support to grow your business and access enterprise level health tech system. Some of the companies on the CharmHealth hybrid cloud include these companies which have novel business models: Physician Promise, My Diabetes Tutor, Telemine, DocTalkGo, Get Cleared, Kita MD, Swasa, and so on. You will be hearing from some of these and other impressive startups today. So what can you build on CharmHealth today? Welcome once again to an exciting day of brilliant innovations to change the world of health tech. We cannot wait to see what you've built. Thank you very much and hope you have a very engaging day today. Thank you. We will be introducing our first speaker today. Michelle Kaluchi is a lawyer, serial entrepreneur, and venture capitalist with Digital DX Ventures, alongside her business partner, Ted Driscoll. Digital DS invests in startups using AI and data to better diagnose and treat illness. Michelle is the West Coast ambassador to the Nobel Laureate Foundation, serves on the board of Nephrosan, advisory boards of eHealth Analytics and Quartilia, has regularly guest lectured and mentored students in Stanford School of Engineering for global marketing and entrepreneurship. Michelle has been a Huffington Post blogger on female entrepreneurship and an award-winning expert on eLocal. She was voted by the Business Journal as a Silicon Valley Woman of Influence, featured in the cover story of Women in Legal Technology in the American Bar Association Journal, named a person to watch by Gentry Magazine, and has been featured in stories on NBC Inc. magazine, the Mercury News, Redbook, and the Washingtonian. Michelle has served on charitable boards, including NOFAS, Hope After Divorce, City Heart, the Georgetown Philanthropy Group. She has a bachelor's degree from Georgetown University, a law degree from Georgetown Law School, and a master's in fine arts from the American Film Institute. She speaks 3 languages and lives in Portola Valley with her 4 children. She's also the author of 3 granted patents in legal technology, with 2 more pending in other areas. Welcome, Michelle. Take it away. Unmute yourself. Yeah.
Yes, thank you, Pramila. And good morning, everybody from my offices in Silicon Valley. Yes, I'm in my office on a Saturday morning, but very excited to be here today and speak to all of you and hear what you're going to be presenting throughout the day. Just over a year ago, COVID-19 attacked our immune systems. This life-threatening illness put people on ventilators, kept children at home from schools, and closed down our world economy. In just under 12 months, our diagnostics went from a week to 4 days to 24 hours to a few minutes. We developed vaccines in 2 shots, then 1 shot, and now we're starting to attack the root cause of viruses themselves, embedded in receptive genetic code, instead of just addressing and minimizing the effects of the virus. Who knows what comes next? The 21st century is the century when we bring together 2 highly advanced verticals. I call it the age of tech-lightenment. On the one hand, we take the last 50 years of scientific research and innovation, including breakthroughs in decoding of the human genome, PCR testing, recombinant DNA, antibiotics, and stem cells, in addition to all the massive biobanks we've created at universities, health systems, and government institutions, and all the groundbreaking work in areas like microRNAs, proteins, telomeres, exosomes. And on the other hand, we combine it with the last 25 years of technology, where computing power has skyrocketed. The smartphone was invented and forever changed the way we communicate, transact, and ingest information. And the daily acceleration of the capacity, scale, and pace of algorithm development, machine learning, neural networks, and artificial intelligence. With these 2 giant fields combined, we get advances in healthcare like CRISPR, the likes of which we've never seen. One simply can't underemphasize the importance of technology in medicine. Our bodies have become massive mathematical problems to be solved. We've literally digitalized the data from our bodies, uploaded it to our computers, created algorithms and machine learning to solve problems on our computers, then took those solutions and translated them back into a form that can be reinserted in the body for treatment. That's amazing. And through it all, we have learned just exactly how big of a big data problem our bodies really are. We found that we have 100 trillion cells in our bodies. Each cell contains its own nucleus with 6 billion base pairs. It's our genome. Personalized medicine is critical. We have genetic diseases. We have epigenetic diseases where methylation patterns turn things on or off. Stress can cause illness by affecting changes in the methylation. Inside our body are different microbiomes with bacteria floating around inside of each. In our stomach, throats, lungs, our skin, there are 1 quadrillion microbes in our bodies that change daily. That's 10 times as many cells as make up our bodies. And my business partner used to like to say, we are massive cruise ships carrying all of these things around, dropping some off, picking others up wherever we go. And by the way, those 1 quadrillion microbes I just mentioned, well, they also have genomes and nucleuses, and we need them mostly to digest food. Unfortunately, sometimes they cause us problems like methicillin resistance. Then there's our immune system. We have 1 to 5 billion distinct immune cells in our bodies that change daily. These cells contain memories of past illnesses or attacks we've successfully fought off. Cells that can kill if they see another one of those attackers. Our immune system is incredibly powerful, as we are now seeing with immunotherapy. But when it's out of control, we get autoimmune diseases. And then there's our virome. We all have viruses running around in our bodies, as we are all now well aware. Snippets of that viral code are constantly trying to replicate. And when we can't keep that replication in check, they take over and we get sick. We also have a communicome that acts like an insulator and a proteome made by genomes in the body. Each of these mini worlds have internal wars that come from the core of important diseases in the body. And we need big data to track, quantify, identify, and counteract all of these attacks. Now, would it surprise you to know that those numbers I just quoted that make up the human being, those 100 trillion cells with 6 billion base pairs and 1 quadrillion microbes and 1 to 5 distinct immune cells, environments, communicomes, and proteomes, are the exact same components that make up a Great Dane? Interestingly, what makes us different than a Great Dane is how they are arranged. And that arrangement is what reflects and dictates how we address problems that come up. And the arrangement that dictates the problems that come up, relatively speaking, it seems like a very small difference, but impactfully, those differences create drastically different reactions to types of drugs or propensity to contract different types of illnesses. What that means is, if we are truly to diagnose and treat people effectively, we must get better at personalized medicine. Previously, without technology, there was no way to know what was really going on without years of research. The microvariances in our genetics, epigenetics, microbiome, epibiome, exosomes, telomeres, proteins, etc. But those differences and the ability to detect them can be the difference between life and death. We have to personalize medicine, and we have to find new ways to pay for it. It's simply too much for our human minds and hands to process. Enter technology. Technology has tools to help us manage all of this. Every bit of information is a data point, aggregated, structured, parsed, and projected out by technology. We use algorithms, machine learning, neural networks, artificial intelligence to extract from all this data what is really going on and to predict what will fix it for that particular illness and that particular person. Researchers spent years looking for and testing microRNA, or looking for vaccine design cycles that now take seconds to find. We are truly experiencing an age of enlightenment in healthcare. Technology is shining a light in those dark corners we could never see, or way out past those horizons, well beyond human vision, and bringing that information, capacity, and now amazing insights into the hands of doctors and their patients in a very real, functional way. And all of you are part of this movement. Every new exploding healthcare vertical is one enabled by technology. To touch on some of the most exciting, ironically, COVID has gifted us with the recognition of the critical importance of telehealth. And payers have finally listened. Our government has pushed to disrupt the regulatory process, which kept so many companies from having enough money to reach the market. And the regulators have listened with their breakthrough designations and fast-track solutions. We need technology to scale our capacity to help people access healthcare in remote areas, at home, to manage massive personalized data and treat people as they are with all their comorbidities and complexity. In digital therapeutics, we are finally learning and accepting that healing does not have to come in a pill, and that loneliness, depression, anxiety can be diagnosed and alleviated digitally and remotely with tremendous success. Medical imaging has jumped leaps and bounds with three-dimensional multi-pixelated imaging, no radiation, all with the data we are already getting. We're just getting that much better at interpreting the data and scaling the insights. Diagnosis and monitoring is no longer a stagnant point in time thanks to wearable technologies. We have watches, headsets, clothing, iPhone, and small external devices constantly aggregating data from our day-to-day routines, rhythms, monitoring and recording the fluid in our lungs, our body temperature, hormone levels, sugar levels, our diet, and our mental health. That can set off all alarms when something is out of sync. We are going to see the day when our doctors call us to tell us, hey, come in, I need to see you, something's off. Or go to the drugstore and pick up this prescription I just called in for you. Technology is keeping track of our health for us in a way we can't do for ourselves. And we are finally accepting that legacy systems don't have to work the way they always did, or in many cases didn't. And that maybe, just maybe, they were never designed with the concept of scaling to the billions of pieces of data that now populate patient records. Doctors needing to maximize the dollar value of their time are accepting more efficient AI and data-powered solutions that help them be more informed for a patient visit, better monitor patient conditions in between visits, and be far more personalized in their treatment. On the insurance front, that's very exciting. We see payers are catching up to the fact that tech and data-enabled early diagnostics can drastically reduce the cost of healthcare. About 3/4 of healthcare spending goes to treating late-stage disease. It's estimated that we can save $26 billion in direct costs alone if we catch cancer earlier, for instance, while it's still limited to the organ of origin. New models of insurance abound, better connecting the needs of patient groups to specific features of a particular plan, and helping patients navigate the myriad of choices to make more personalized health insurance choices. Insurers are now finally connecting the risk of late detection to liability and realizing that detriment and cost of a purely symptomatic approach to healthcare services doesn't work. We can now create fully functional limbs for people who lost them at birth, war, from sickness with robotics. And who doesn't love the video of the robots dancing to "Do You Love Me?" We have augmented reality and virtual reality where young students literally walk into the sphere of a cell and look around to bring a greater understanding of our bodies to life. In sensor technology, we have applied mechanical and electrical engineering principles to create nanosensors that can track molecules in our body and let us know where they're going if they're attaching to what we're targeting and delivering micro insights into how effective whatever we are injecting into the body really is. That is just amazing. And we have signal processing technology where we can replicate the signals our nerves send to our bodies to create reactions and replicate those signals from outside our bodies. And then there's femtech. We are now finally starting to recognize, as if we couldn't before, that there's a whole bunch of medical conditions affecting half the population that have not been funded. Femtech is a multi-billion-dollar market. I'm not sure why this is a surprise to anyone when the studies recently came out. One would think, with women making 90% of the healthcare decisions and accounting for 50% of the population, that this vertical would be well funded by now. Not so. But given the experiments themselves in the animal testing have traditionally used only male mice, I guess it should not be a surprise that women, their needs have been overlooked for generations. And on a higher level, we are finally realizing that in order to truly serve the population, solutions must include a focus on problems of traditionally underrepresented populations. The world is comprised of all genders and ethnicities. Given this fact, one would think our founders, C-suites, boards, and investors in healthcare would be more closely resembling the patient populations they serve. Sadly, we are still a long way away from that goal. Believe it or not, women-owned funds like mine are still less than 2% of all funds. And along with that, relationships flows the drastic underfunding of women and minorities, our circle and sphere of relationships. Diversity of thought is what drives better decisions, better outcomes, and reduces risk. The data clearly shows us this, and yet the numbers continue to decrease. We have to do better here. Technology enables a whole new level of understanding. Technologists look and think about problems in very different ways than do scientists. And the reverse also exists. You don't have to look farther than the creation of neural networks to see how science has also directed the evolution of AI. Oftentimes, the most innovative solutions come from people working outside of a vertical because they're not tied to how it has to be, because it just doesn't. And this is why we have been able to make such leaps and bounds in healthcare as we bring technology to medicine. And not a moment too soon. The pace with which populations desperately need innovation to reach and care for their masses is dizzying. The amount of unmet need has never been greater. The shift to focus on diagnosing and treating people with technology-enabled solutions is the future. We are seeing diagnostics identify illness much earlier, enabling pharma companies to identify patient populations in which an illness is still in its most pristine form, still contained in the organ of origin. We can save hundreds of millions of dollars identifying transplant rejection 200 days in advance, in time to save the organs, which are in such short supply to begin with. We can scan the eye in 2 seconds and see Alzheimer's up to 10 years before the onset of damage to the brain. And we can monitor the use of cell phones to identify patterns indicating a spiral in mental health. Just imagine if we get it right at the very beginning. If we go into a doctor's office and come out knowing exactly what's going on in our body, and based on our personal genetics, what treatment will be effective for us. Diagnostics now only receive 5 to 7% of the funding, but dictate 60 to 70% of the patient journey. Think about that for a moment. If we don't have the right key to open the right door for our journey at the right time, we spiral down into a nightmare tunnel of twists and turns, trying this, changing that. Nowhere is that more visible than the constantly adjusted chemo cocktails served to dying cancer patients every day. We have to get it right from the start, and technology can help us get there. This shouldn't be that hard. We have massive amounts of data and insights from what our body gives off in urine, feces, breath, saliva, dead cells, and from observing our skin, eyes, gait, behavioral patterns. With all of this data coming out of our bodies, we shouldn't have to worry about knowing what's going on inside. I'm happy to say, now that diagnostics are being supercharged, enabled by and with technology, this is our future. I almost feel like we can't even use the name diagnostics anymore since it has changed so much. It's more like technostics. And that's where all of you come in. The unintended consequences of COVID is that we could all be here today, regardless of our ability to afford flights, pay for hotels and travel expenses, to convene as one in a time when we all deeply need to unify as people. Countries all over the world, it's incredible how many people we can bring together. From vastly diverse socioeconomic income brackets, from gender pools, you are our hope. You and your diverse points of view, you with different life experiences, with varying expertise, all coming together in this online Charm Health conference today to bring us your new ways of thinking, of doing, to share, to collaborate. Thank you for your time. Thank you for your ideas, your dedication, your collaboration, your innovation. And most of all, thank you for working so hard, because I know it's incredibly hard to convince people to support your innovations, to make a difference in the lives of us all. Thank you.
Thank you so much, Michelle. That was a very insightful tour of the landscape of innovation in healthcare. And you really did a great job setting the stage for all the presentations today. Thank you so much. I know you're a busy person and you've chosen to spend this day with us. Thank you.
It's a very important day, a very important event.
Thank you. So let's get started with our first pitch session. We will be going to the set of 4 companies that have very interesting business models and are launched on CharmHealth Ecosystem, and they will be talking next about their startups. And judges, please be ready to do your rating. Thank you. So the first would be starting with my diabetes tutor.
So good morning all. Thank you, CharmHealth and iValley for this opportunity. I'm Dr. Sahas. I'm the CEO founder at My Diabetes Tutor. My Diabetes Tutor is a telehealth program for diabetes education. So diabetes is a challenge, and My Diabetes Tutor focuses on educating patients with diabetes via telehealth, via video chat, and patients receive their education either from their home or from their doctor's office using a HIPAA-compliant telehealth platform. My Diabetes Tutor is the first telehealth program in California to get national accreditation from AADE. We currently have 18 certified diabetes care and education specialists working to provide education and improve patient outcome. The educators are culturally diverse. They speak foreign languages. To become a certified diabetes care and education specialist, you have to be a RN or a registered nurse or a dietitian or hold a degree in PhD in nutrition. They work for like a period of few years in diabetes and then sit for the exam and become diabetes care and education specialist. So they are not just health coaches. So why it's a challenge? Over 34 million Americans are diagnosed with diabetes in our country. And as per CDC, of that 34 million, less than 50% of the patients receive some formal diabetes education. The reason why less than 50% receive education is because there's a shortage of educators all over the country. And if you take like underserved areas, underserved smaller towns in the country, in this country, they have no access to diabetes education. And that is the motive behind me creating My Diabetes Tutor. And patients here are receiving diabetes education which meets national standards. Our program is approved by the CMS, by Medicare, and several PPO plans, including United Health, Aetna, Blue Shield. We are implementing four large health plans in California at this time. And for universal care, we are implementing for 16 counties in California. And our biggest implementation is going to be Department of Defense. TRICARE will be implementing over the next 4 months. And TRICARE and Department of Defense, we have 15 base hospitals in California. So the solution is we are providing one-on-one telehealth diabetes education sessions, video sessions. My Diabetes Tutor is unique. There are no other programs in this country working in this model. We work directly with patients. Patients can self-refer, PPO patients can self-refer and take charge of their health and improve outcomes. We work with solo practices, small group practices, and hospitals. If you take solo practices and small group practices, they cannot afford to employ a diabetes educator. So collaborating with My Diabetes Tutor will bring diabetes education to their office. Hospitals, running a diabetes education program involves lots of resources and time, and working with us, hospitals need not run a diabetes education program. And third thing is we are also working directly with insurance companies. Insurance companies are liking us. We work with patients, we improve their health, we reduce the diabetes related complications. Insurance companies are liking us. We are saving lots of healthcare dollars spent on treating diabetes related complications. So it's a win-win situation. We work with patients, providers, and insurance companies. So that's the model how My Diabetes Tutor is operating. So one thing to highlight is we are reaching out to the most rural and remotest community, the counties and cities in California. So people who know California, there are towns like Avenel, Coalinga, Kettleman City. These are tiny towns with no access. We are able to reach out to these small towns. And we provide education for type 1 diabetes, type 2 diabetes. We provide 1 hour session each for type 1 and type 2 diabetes. After providing the 5 sessions, we also continue following the patients for life and provide support. And we also provide education for gestational diabetes, pregnancy-related diabetes, and pre-diabetes. We are adding a insulin pump support and education starting from May, which is basically an endocrinology domain. And by treating pre-diabetes, we are working with patients so that they don't develop diabetes. So you have around 80 million Americans living with diabetes currently. So our goal is to decrease the new cases of diabetes in this country. There's no medications, medications available for pre-diabetes. It's education, lifestyle changes, the treatment option for pre-diabetes. So My Diabetes Tutor, it's not an idea, it's already implemented. We got the approval for the program during February 2020, just before the COVID. And we went live during August 2020. We looked at our performance during the first 3 to 4 months, and our outcome is outstanding. We reduced the A1Cs, we improved the cholesterol profile, and patients also showed like some improvement in kidney function after attending the program. So our outcome measures are good. And the behavioral goals, our target was to reach at least 60%, but we met target 70 to 100%, improving from baseline of 40 to 69%. And patient satisfaction, if you don't have patient satisfaction, you're not going anywhere. But if you look at our patient satisfaction, 100% of the patients marked very good. So competitive analysis, it's the first telehealth program to get accreditation from AADE. It's a statewide program currently, and we are looking forward to making it into a nationwide program 2022. Diabetes education can lower A1Cs by at least by 1%. And studies have shown that attending 3 sessions of education reduces A1C by up to 1.2%. That is more than a medication effect. And by decreasing weight, we can improve the blood pressure and cholesterol, so the patient outcomes improve. We did like extensive research before we selected the EMR, and we chose CharmHealth because it's user-friendly, and it gives us the capabilities to do lots of data analysis. Patients do like 2 types of flow sheet before attending the sessions: goals and action plan, and patient baseline data. So we look at the measures pre-sessions, we look at the measures post-sessions, then we do a data analysis, and that's how we are able to determine the progress of our program and patient improvement. And insurance companies are liking this, the capability to do data analysis. And the program about myself is founded by myself. I'm a board certified endocrinologist. I'm a faculty at Loma Linda University. I've been in private practice for over 13 years. Being in practice for 13 years, I clearly knew what patients need, what providers need, and what the insurance companies are looking for. And that's how My Diabetes Tutor was created. It's not just me. We have talents all over the country, experts in the field of diabetes who worked with me and are working with me to create contents, and highly talented professionals are delivering high quality care. We have an excellent administrative staff with lots of healthcare experience, holding a master's degree in healthcare administration, running the program. We are also starting an outcome study in collaboration with Loma Linda University later this year. We are waiting for the implementation with the 4 major health plans, and then to start the outcome study. And motivation for me to participate in this challenge is networking and possibly reaching out to investors and obtaining funds to grow the program to a nationwide program later in the future. And summary, My Diabetes Tutor is making positive changes in people's lives. Education is the key in learning how and what steps you need to take control of your health. We are bringing in my high quality education to patients to prevent diabetes related complications. Diabetes is the 7th leading cause of death in the country. Diabetes increases the risk of strokes and heart attacks, which is the 4th and 5th leading cause of death. And hopefully we are hoping one day to benefit 30 million Americans living in America. And to the judges, diabetes education is an unmet need. There's a big opportunity to help millions of Americans. And My Diabetes Tutor is the solution. And it's not an idea, we already implemented it, and it's technically viable and financially viable to run the program. Thank you.
Thank you, Dr. Sahas. Pramila, are you there? Can you hear us? Okay. Hey, Dr.
Yeah.
Sahas, thank you so much. Yeah, now we'll open up the floor for the judges to ask questions. So again, there'll be only 5 minutes. So if you have more questions, or if you want to talk to Dr. Sahas, he's always available via chat here or on Hua. So please, judges, go ahead.
There is a question on the chat. You could look at it.
Hi, Prem. This is Yuli Cheripalli. Great presentation. Thank you. One question I had was, do you have any data on how your system is changing the hemoglobin A1C? Do you have any studies?
So we collect the patient baseline data at the time of before they start the sessions, and after the sessions, patients we collect the information, and we look at the pre and post session hemoglobin A1C. Yes, we do have the data, and we published that at our first advisory committee meeting during month of February.
And what does it show?
It showed, so the average A1C of the patients who started in this study in our program was 7.3, and the A1C came down to 6.8. The reason we have only a 0.5, 0.6% drop and not a higher drop, because our patients didn't start with a much higher A1C. If our patients had started with an A1C of 10 or 11, then you will see a drop of 1 to 2%. If they're already near control, the drop in A1C will be less, but a drop in A1C of 0.5% makes it uncontrolled to controlled diabetes is a significant drop.
Thank you. And how are you paid? How do you?
We have different models. We are paid by Medicare, PPOs, and few of the health plans, they are paid per 1 hour session visits. And we have the Blue Cross Medicaid plan who are working with us to give a contract for a flat rate for all the 6 sessions. So we are open to insurance companies, but currently we are working for fee for service, fee for visit.
Thank you.
I have a question. Can you guys hear me?
Yes, I can hear you.
Okay, great. Do you, I was a little confused about the competitive analysis part. What really sets your company apart? I mean, I see that you have this accreditation, but what's to stop other companies from getting that accreditation? What really sets your business apart?
There are no other company in the country which provides a unique model where the patients can access the program working directly with the health plans and providing services directly to providers through their offices via kiosk. This model, there are no companies at this time, and mine is the first probably in the country to have a similar model.
So patients come to the clinic and
so the patients can go to their doctor's offices, and we set up kiosks at their doctor's office. So the patients who are not tech savvy, who don't want to deal with computers, they just go to their doctor's office and they log in at the doctor's office and get the education, receive the education from the educators.
Thank you so much for clarifying.
There are a couple of questions in the chat. This is an amazing initiative. Have you taken into account how compliant patients will be with their education? It's a good idea, but what guarantees that the patient will religiously access and absorb the learnings? And the other question is, do they help with meal planning and family meal planning?
Yes, we typically try to involve the family during the sessions, and we have one session just for diet and nutrition and meal planning. And how much patient is compliant? Typically a physician gets 15 minutes for a visit. There is no way physician can provide 6 hours of education to a patient. So when the patients come in, they come with a neutral attitude. But after the session, The patients are compliant and they're making positive changes. That's why our patient satisfaction is 100% on our study.
So I think that's the end of questions. So let's move on to the next participant.
Thank you so much.
Hello, everybody. Can you hear me?
Yes, yes.
Okay. Hi. I can't present until the prior presenter shares.
I think Prem just stepped. Oh, yeah, there.
Okay, let me try here. Okay. Can everybody see the screen?
Yes.
All right, fantastic. All right, thank you, everybody. It's nice to see everybody. Good morning. My name is Shadi Hanan. I'm a physician. I'm a structural interventional cardiologist. Happy to be here with all of you and to showcase all of you what we've been working on at Physician Promise in conjunction with CharmHealth. The unmet needs in couples health. 60% of patients avoid seeking doctors. 53% of patients are embarrassed to discuss issues that are related to their health with their spouse. And 36% of patients hide medical problems. And there's no platform that currently exists for couples healthcare. And we treat multiple types of disease states that are very sensitive to discuss, such as erectile dysfunction, hair loss, performance anxiety, skin disease, whole range of different skin disease, such as acne, rosacea, hyperpigmentation, and others. Menopause symptoms, hypoactive sexual desire disorder for women, smoking cessation, and birth control medications. So what is Physician Promise? We're a telemedicine platform designed to enhance a couple's quality of life through personalized digital content, expert community, and specialty prescription medications. We are a one-stop shop for patients. This is a new type of telemedicine, an asynchronous type of telemedicine here to help patients nationwide. We diagnose their medical issue. We prescribe medications for them. We deliver the medication straight to their door. We educate patients on their disease states, and we build a community for patients and others to come learn about the different disease states that they may suffer from or that their partner suffers from. And we'll go more into that, in depth into that as we carry through this presentation. But before we go further, Physician Promise would not be the success that it is today without our team. I'd like to introduce to you some of the other team members. Anand Narayan, he's a co-founder of mine. He's a CTO. We both met at Cornell, where we both got our MBAs. Harsh, he's our data manager, and Suhas works with our pharmacy manager. We all bring different things to the table. Like I said, I'm a structural interventional cardiologist, board certified, trained at multiple wonderful institutions. And so through my history of speaking with patients for the past 15 years, really come to understand different things that patients are suffering from. And that's how Physician Promise was born last year. We have wonderful advisors on our board of advisory. Dr. Brooks, he's the co-founder of Teladoc. Dr. Shen, he's one of our professors at Cornell, supply management. And Dr. Nekla works at Blue Cross Blue Shields as our senior medical director. We spent many, many months before the pandemic began talking to patients nationwide, having multiple conversations and surveys about what it means to use telemedicine. And after speaking with thousands of people, this is what we boiled it down to. That the age range is 35 to 65. They make about $80,000. They're married and they want good quality, convenient healthcare. The female, she doesn't like discussing her issues with her spouse, doesn't like confusing online buying processes, has premenopause, skin disease, hair loss, and anxiety. Her husband or her partner also doesn't like talking about things that are really sensitive with his spouse or with doctors, doesn't like admitting he has a problem, may suffer from ED, smoker, and hair loss. There's a huge market opportunity to the disease states that I mentioned earlier. It's a $5 billion market for our SOM when it comes to couples healthcare. The entire market, the TAM, is about $130 billion, but we're going after that slice where it's specifically for couples healthcare, and it's a $5 billion market. Here's just some imagery for the audience today and for the judges to showcase our branded medication designs, what we've been giving to our patients, and we work with a specialty compounding pharmacy that helps put everything together and delivers it to our patients. And here's a patient testimonial. We have multiple patients over the past couple of months, but this one really spoke to us. She said, "It only took me 10 minutes from start to finish. This was very convenient since I was unable to get a doctor's appointment elsewhere for 30 days. Physician Promise made this super easy for me. I will definitely be back." And she was very happy, and she brought her other colleagues who were suffering from different disease states that we help cure. And the Promise community, this was in addition to what I spoke about initially, is that this is a free, professional, and credible medical advice network for patients. Patients can come here and learn from other physicians, exercise coaches, nutritionists, and patients, where they can read articles that are written by these experts and have dialogues in an anonymous fashion with other people who are suffering from the same disease state. So here, I like to kick it off to Anand, my co-partner, to discuss the rest of our technology.
Thanks, Shadi, and thanks, Charm, for setting this up. We really appreciate everyone's time on the call today. So real quick, going through the value to users, and we're comparing ourselves here to, telemedicine and traditional doctor's visits and online and traditional pharmacies here. From an ease of use standpoint, right, we can do this from anywhere at any time. There's no need to set up appointments. There's no coordination. There's no cancellations, right? The patient can do this at their own time. From a cost point of view, we actually don't accept insurance. There's no co-pays. We're able to have cost savings that we're able to pass that along to the patients because the prices aren't set in advance. We have free shipping, and it's really pay for what exactly you use. And from a benefit standpoint, right, we're discreet. It's a time saver. Pricing is extremely transparent before you even start the process, so everyone knows exactly what it is. And we have specialized compounded medication that really helps our patients. We're really a one-stop shop. And of course, we have some comparisons to the other types. So what does our business model look like? What are we trying to achieve here? Of course, at the beginning of the process, there's some user acquisition through either paid or search engine optimization and organic growth. And then what happens, the user comes to our website and they go through what's called a virtual visit. This is live. You guys can actually go to physicianpromise.com. You can go through our virtual visit. And it's a simple adaptive questionnaire, which changes based on how the patient answers the questions to really get to the root cause problem. And what we've done is we've allowed patients to sign up later on in the process so that they can actually play around with the system first and see how easy it is to use before they commit to something like this. And there's a lot of patient education there. Of course, when the patient goes through the process, we show them some medications. They choose the medication that they want, which is all based on how they selected their responses. And we know it's all checked and double checked to make sure everything is appropriate. Once the patient selects the medication, they check out. And then, of course, we have a method of retargeting those patients through our chat functionalities and other methods to make sure that patient is taken care of from ongoing care perspective, and that the medication is working to their needs. From our internal workflow, now, once the questionnaire is done, all of that flows into Charm, right? So we have all the APIs attached that flows into Charm. All the information is there, and our physicians log into the Charm network to look at those patients. So we first have a coordinator that goes in there, assigns it to a physician that is in that state, that is licensed to prescribe in that state. Our physician looks at that, approves or disapproves the prescription based on the risk for the patient. And then that passes on to the pharmacy through the ERX functionality. Over there, we dispense the medication, we package it, we ship it to our patients, which is all discreet, comes within 2 days, all done through FedEx. And then, of course, we have a customer support mechanism. On each product, we have over a 50% margin on average that we're providing to patients. So what's the technical viability of this? So we have actually already served 10 to 15 patients. So we know this works. The patient has gone through the process. These are not patients that are known to us. They are patients that have found us through some channel and gone through our platform and received the product, and we followed up with them. So we know it's technically viable. Of course, Charm is the backbone to this entire server. Everything that we do is through Charm. We do have a front end that patients interact with, but everything we do is through Charm. We are LegitScript certified for those that are aware what LegitScript is. We are web accessible across the board, and we do follow all GDPR regulations. What we want to do in the future once we get to our Series A funding is we want to integrate AWS SageMaker into the process. Charm allows us to do a lot of data analysis. It's a huge advantage to us. And we can use AWS SageMaker to analyze patient risk levels, right? For certain medications that we're providing. We're able to take care of customer support through a chatbot without using a person that's there. And of course, have a medical person that takes care of medical related questions. We're able to do root cause identification analysis to diagnose patients before it actually happens. And Google's already done a bunch of these things, so we know it's possible once that data is collected. And that'll help us understand what the next big product is and help patients avoid the problem altogether. At least that's our goal. And we want to use robotic process automation through UiPath to automate a lot of these processes as well. And it can all be done built on the Charm platform. So how are we using Charm? So Charm has 7 products. We are using 5 of them. So our platform is completely integrated with Charm. I mean, there's nothing we can do really without them. From our electronic health record, right, from practice management being a 50-state model, from patient engagement and retargeting across the board, from telehealth, and of course, communicating with patients. If we look at a functionality and API standpoint, right, we're using the Encounter API for each time a patient comes onto the platform. We also use it to see when a patient fills out information, submits their questionnaire, because it allows us to send them automatic notifications that really help us. So whenever an order is placed, whenever their order is received, whenever a physician writes a prescription, all that can be done through the Encounter API. We're using the questionnaire API from adaptive questionnaire standpoint to make sure all of that's uploaded. We of course have the patient document and patient demographics API through this entire thing. Our physicians are using the chart note functionality. And since it's a 50-state model, we're using the facilities API to make sure everything is coordinated properly. One big plus here is that our physicians and patients have the messaging function on the platform that they can chat with each other. Patients interact through our web forum. Doctors are on the Charm side of it. And we've connected both sides so that they can communicate with each other. And it's a two-way communication stream in case there's any questions or risks that need to be answered. And finally, of course, we use the ERX function to send everything to the pharmacy. So we are using Charm across the board. You know, there is no other third party that's involved throughout our startup process. And we really appreciate Charm for closely working with our teams. I think our teams are also experts now on Charm's technology, just because they've worked very closely with us throughout this process. And we'd like to thank Venki especially for making sure that coordination happened to make this all successful. So overall, you know, we want to reduce medical inequalities through affordable and accessible healthcare, especially in areas where it's very difficult to get an appointment, where it's very difficult to get these medications. And I think this really solves that problem. So lastly, thank you very much. We are Physician Promise. We are open for any of your questions. You can find us on the social media icons. The last thing I would like to mention is we have raised our convertible note fund, our seed funding of $500,000. And now we are looking to move on to Series A as we start gaining revenue and traction. Thank you.
Yes, thank you, everybody.
Please look at your chat for some questions.
This is Yuli Cheripalli. This is a great presentation and a great use of technology. Thank you for doing this. When you said that they pick the prescription first and then go to the physician, is that what happens?
Yeah, so basically the patients will come on, they will have some inclination as to what is bothering them. Through our system, it helps gauge them. First of all, they'll have to specify which state they're coming from, and then it'll showcase the different disease states that Physician Promise at this time is caring for. They'll then be able to read about their disease states, and they'll go through it. Even if they don't know what disease that they have or the complaint that they have, they'll still go through the medical questionnaire. The medical questionnaire is adaptive. And at the end of it, through our algorithm, which is proprietary, it will then tell the patient, yes, you were diagnosed with XYZ. We're able to treat it with these type of medications. If you would like to move forward, select the medication. One of our physicians will then review, obviously, everything that was input by the patient, and will then approve or disapprove the medication based on the medical expertise.
And here, how is this different right now from a lot of the competitors, the Hims and Romans, for what you're offering?
Sure. So we're going after different disease states than they are. Of course, out of the three of us, we're all going after ED. We're all going after hair loss. We're all going after performance anxiety, but we're also going after it in a different way. We're going after it with the promise community, where this is a way for patients to interact with one another in an anonymous fashion, to learn from other physicians, other patients who are suffering from the same disease states. You know, no one can say that they have the territory for a specific disease. The way we're all coming about it is in a different way. The different medications that we offer are also different. We're working with different pharmacies than they are, and we're offering compounded medications that other pharmacies and other telemedicine players do not have. Anand, would you like to add anything to that regarding from a technical standpoint?
Yeah, I mean, just to add on to what Shadi said, I think the positioning and branding is much different. We've talked to thousands of patients, and of course, those two companies have done a phenomenal job. In 3 years, they've blown up, and they're really the ones that have led the market in a certain way. But there are patient demographics that are not comfortable with those platforms either. They're more lifestyle brands, is how I take it, right? And that's what they're really going after. And of course, that's great, and they've done a phenomenal job. But some patients aren't comfortable with the lifestyle brand, or they might not take it as seriously as more of a medical profession facility. Right. So there's two different patients, and we only learned all of this through the interviews, and we did an innovation project with Cornell. And from learning with that, you know, say someone that's maybe 60 years old or 55 years old, I don't want to bucket people, but you know, a lifestyle brand is maybe not what they're going for, right? In that sense. So those customers are more, they want more something that looks more credible to them, right? And the Roman and Hims, I feel like, go after more of a younger demographic. More than the older demographic. And I think our goal is to really capture that older demographic and make them comfortable with something like this, so they're willing to go on it and use it. So I think that's a big differentiating factor. And that's what we've learned from interviewing all these customers, that we know there is a segment there that is untapped because they are not comfortable, or that's just not where the advertising dollars are going to find them either. And we know that's definitely the case, and that's what we're really going after.
Okay, thank you. I think that's the last question we could take because of time. But we thank everybody, and we especially thank Charm for all the effort and the support that you've given us over the past month and over our future endeavors and relationship together. Thank you, everybody.
Thanks, everybody. Appreciate your time. And we're open to questions. Our email addresses are up there, and you know, we're ready to answer any questions on a one-on-one basis if anyone wants to schedule any time with us. Thank you.
Amanda, please go ahead.
Okay. Hi, everyone. My name is Amanda Gorman. I am a pediatric nurse practitioner and the super mom to 2 small children. I am also the founder and CEO of Nest Collaborative, and I will begin sharing. All right. So I founded Nest Collaborative back in early 2017 after experiencing a dearth of resources for women when it came to breastfeeding. I first came upon the issue as a primary care provider out in San Francisco, working at San Francisco General Hospital, finding that all my patients were trying to breastfeed and we were struggling as a clinic to support them. I later found out firsthand how challenging breastfeeding can be when I gave birth to my first child and really struggled. So I'm thrilled to present our work at Nest Collaborative in conjunction with CharmHealth and show you how we're really making breastfeeding easier for women everywhere. So breastfeeding saves lives. It reduces diseases like cancer, diabetes, heart disease, sudden infant death. And consequently, we're seeing the highest initiation rates in decades, with more than 85% of women in the US trying to breastfeed. Unfortunately, over 70% of them fail, unable to meet just the minimum feeding recommendations to breastfeed exclusively for 6 months. And this costs the US over $18 billion every single year in healthcare costs directly related to their failure. So why are they failing? Well, we simply aren't giving them the resources that the research says they need to actually succeed. Their OBs and pediatricians simply aren't trained in lactation support. And those who are board certified lactation specialists are in shortage. We only have about 3 to 4 of those per 1,000 babies born in the US. And moms simply aren't educated enough going into breastfeeding to know what to expect. So they go in virtually blind, unaware that they're likely to encounter struggles in breastfeeding. They don't then know where to source care, and they certainly don't know that their health insurance should be paying for it. So what we're doing at Nest Collaborative, utilizing CharmHealth as our base platform, is allowing women to come and find the support they need at the click of a button. They simply come to our website, book an appointment for as soon as an hour. They give us our medical history that we need to review. They submit their insurance information, and we're able to offer them a one-on-one virtual visit with one of our board certified specialists with no out-of-pocket costs. She comes to us, we provide a treatment plan of care appropriate to her. We circulate that back to her digitally through the PHR. We're also able to circulate that to her OB and pediatric providers for continuity of care. We've simply taken what the evidence shows works to extend the duration of breastfeeding for women and wrapped it up into an all-in-one, affordable, easy to access solution. Our team are simply the cream of the crop. They're all board certified, internationally board certified lactation consultants. Most of them are also duly certified as nurses, pediatric and NICU, some also nurse practitioners and dietitians. They simply walk mom through this journey from beginning to end under a preventive model. So we begin with her journey all the way before baby arrives, doing a more precise risk assessment about barriers very specific to mom, any medical issues she may have that would affect breastfeeding, such as thyroid issues, breast augmentations or surgeries, mastectomies. We're there then during the first few days when baby is home and you're likely to see latching or positioning issues, weight loss and jaundice. And at every transition point thereafter, changes in milk supply, teething, starting solids, returning to work, having to build a stash from which to draw when she's at work, or ultimately weaning or her next pregnancy. We survey through the use of Charm and the post-feedback surveys, every woman after every visit. We've seen over 2,000 mom and baby dyads to date, and they absolutely love what we're offering. And no, this is not just a COVID thing. Telehealth really addresses barriers very specific to breastfeeding, most namely the unpredictability of breastfeeding problems and a shortage of the providers who can help. We really emerged as the initiator in this space and are really fortunate to continue as the leader. We're most notably differentiated by our payer reimbursement model and our preventive care model. So why Charm? When I went out there and started this in 2017, there were only a handful of telehealth platform options. They ranged in price, they ranged in features and bells and whistles. And what Charm really offered me as a startup founder was an affordable platform, but almost equally importantly was a customizable platform. We were entering into a new specialty that had not yet been billed for to insurance companies and had not been yet carried out through a telehealth. So I was able to really customize the platform to the specialty as I saw fit. And we were able to integrate this secure and functional telehealth feature, integrated billing. It was mobile friendly. And they have a responsive team when I needed to reach out and get the help and the support. They've always been responsive and wonderful to work with. And as we've moved forward and grown, the API integrations they offer have been wonderful. We're currently utilizing 5 APIs to date, which is patient demo, insurance, calendar, and appointment type, and provider, which allows us to offer a more customized front-end scheduler for data sharing. And our roadmap does include expanding out into more group telehealth visits, but really more customizable data tracking and reporting, because the data and what we're doing is what really drives the health outcomes that we want to be building on in the next couple of years. I'm fortunate to have finally built out a team that's really supportive of the mission that we're doing at Nest Collaborative. I, again, the founder and CEO, come along with Anna Zornosa, our Chief Revenue Officer, which brings a wealth of information working with startups, including her own Ruby Ribbon. She's raised up to 50 million, I think, in her lifetime. So she's been a wonderful asset for us over the last few months. And we now have a robust team that is allowing us to grow and scale. We were fortunate to be well prepared when COVID hit. This is a brief look at the last year, more or less. We're now moving into our 6th quarter of consecutive growth. We operate under a fee-for-service model, driving over 90% of our revenue from payers directly. We acquire our consumers through direct paid and organic search, as well as through provider referrals and partnerships. And, I bootstrapped this company up until October of 2020, when we brought in our first $200,000 under a safe note, at which point we started really building out our team. We expect to hit an ARR of $1 million in Q3 of this year. All of our key drivers have and continue to improve. This is a comparison of January 2020 to January of this year, where we saw a 1,200% increase in the patients that we see per month, an increase of 71% in the average visits per visitor, an increase in the number of prenatal consults, which is really driving our preventive model, and a 60% increase in those who return. We are able to do this and maintain about a gross margin of 64%, and the payers on our left are those with whom we're contracted with currently. Again, we took in our first funds in October, started building team, and I'm excited to say we actually closed our seed round in January at $2.1 million, which will really allow us to keep our continued drive for leadership in the space, expand our marketing, and build on our technology and grow our team. We expect to raise a Series A at the end of this year and are actively scheduling meetings for this quarter. Our current partnerships include large OBGYN IPAs in the Northeast and 2 breast pump DME suppliers. And currently in our pipeline is a Medicaid MCO, 2 hospital systems, and expansion into 4 different states with our IPA partner and 2 additional DME suppliers. I'm thrilled really to be included in this challenge. I've really enjoyed working with the Charm team. Shouts out to Venki and Sabra and really the whole team that has kind of watched this company grow from its infancy. And I appreciate the invitation today. Thanks.
Are there any clinical outcomes for this of how it improves breastfeeding?
Yeah, so the data that we're currently tracking are the same data points that the CDC looks at, which is any or all. So any or exclusive breastfeeding, the 3-month and 6-month mark. And we are currently tracking that data and providing our own research. The other data that I've done qualitatively and was able to present at a poster with the American Academy of Pediatrics was more qualitative and retrospective in moms' attitudes and beliefs towards utilizing telehealth for lactation support. And over 96% of, I think, our 92 respondents found it easy to use and convenient. Over 70% would choose it again, with a high degree of those saying if their providers had made the referral, they would have reached out earlier for support from us.
And are you relying on billing insurance yourself?
Up until recently, I was the billing department,
Yeah.
But we bill internally utilizing Charm system, and we that allows us for a quicker.
That's where your revenue is coming from, is payers in that way.
Yeah.
So and do you have an idea of what visit codes, like what reimbursements are like for these particular codes?
Yeah, we average for a visit, depending on the payer. When we first started, payers didn't even know how they wanted to pay. They didn't think they needed to pay for this. Then we fought them for it. And then it's been an interesting time because there's been some litigation against some of the big payers, specifically for breastfeeding support. Yeah. So each payer has its own billing guidance, and we average about $180 per visit on the commercial side. Medicaid varies dramatically. But we're looking to hopefully get into a more of a value-based direct contract with the Medicaid providers, just because the outcomes to their, they have a significant ROI for them.
It's far higher than most visit types that you'll see.
Yeah, these are comprehensive visits. They're long visits. They're intensive. They're emotionally draining. But I wanted to make sure that I could substantiate what we were doing, and so the way we chart is the way you would chart a full comprehensive B&M visit. It's a lot. But yeah.
Hey, this is Yuli Cheripalli. How many clients can one lactation consultant handle?
So unit economics, right now, so as not to really overburden, because as I mentioned, these are emotional visits. We're dealing with postpartum women who are really in crisis, but somewhere between 1,200 and 1,500 visits per year for one FTE, one full-time IBCLC. The more prenatal visits we see, those can be a little shorter. We're going ahead and moving forward with our next product launch right now. It launched last week, the Latch Lounge, which are group visits, which will allow us to do a little bit more in less time through small group cohorts, but 12 to 1,500 per year.
Thank
for
you.
an FTE.
All right. Thank you for that presentation, Amanda Gorman. So the next presentation will be coming from Get Clear by Dr. Payal Gupta.
Hi, everyone. Nice to see you all. And those were great presentations. I totally hear that breastfeeding journey issue. So I thank you for that. Cleared, I'm the co-founder, one of the co-founders for Cleared, which is an allergy-based company. This is some of our team. So essentially, we're on a mission to provide allergy care more accessibly to patients, and that's including asthma, allergic rhinitis, allergic conjunctivitis, eczema, and urticaria. So, allergies sometimes get, I'm an allergist by training, and sometimes people say that allergies aren't that big of a deal, but they are, because number one, the cost to society is huge. People don't realize that 10 people die a day, even in the US, from asthma a day. And so there is a huge burden. And with global warming, actually, this problem is just getting worse and worse. And we're going to continue to see that that issue kind of get worse. And so care is expensive, it's inconvenient, and it's confusing. So, and that's really why we launched our company, is because I was approached by my two co-founders wanting to do something in the allergy space because of their previous experience in the regular allergy space. So what we want to do is use doctors and technology, and that's what we've started to do. So we're fully, we've actually gotten our Series A funding. We've raised $1.4 million for our company. And like I said, first we've started with seasonal allergies as our initial kind of mission. And then we're moving into food allergies, skin allergies, asthma, immunotherapy, and sinusitis. And so essentially, it's a model similar to what you've heard about, where you do the online visit through an asynchronous model, and then you get personalized treatment recommendations and then free ongoing care. What we also have done is we've launched some supplements, and our biggest thing is our partnership with pharmaceutical clients. So our first pharmaceutical client is ALK. They're the one of the largest immunotherapy providers in the country, and even in Europe, actually. And so they have something called sublingual, FDA-approved sublingual immunotherapy tablets. And those are, during COVID, this is super important. Whereas normal immunotherapy for environmental allergies, you have to go into a doctor's office to get immunotherapy. This is at home, sublingual. And so that's really what we're working with them for. So our top of the funnel is marketing spend on trying to get people into our site. And what we've done is partnered with ALK because they're spending so much money, trying to reach customers, trying to tell people about their product. Once they tell people about their product, then finding the right providers that understand their product and understand how to prescribe it. That's the pain point. And especially right now with COVID, a lot of pharmaceutical reps are not allowed into a doctor's office. this. And so I think more and more pharmaceutical companies are looking for an alternative way of reaching customers, and then also putting them in touch with the right providers. And so that's really where we come into play. So they're kind of funding our top of the funnel, getting people to our site, doing all of that marketing spend, which is probably the hardest for a startup, which we are. You know, we just launched in November, but we're already seeing average of 150 registrations per month and 30 consults per day. We're also branding generic allergy medications and providing them at a discount for our consumers. And so what I'm seeing as a provider is that there's a lot of people turning to direct-to-consumer care because they've either lost their healthcare insurance through COVID, or they have a healthcare plan that has a huge deductible, high deductible plans, which don't allow really for any sustainable kind of healthcare. And so they're turning to direct-to-consumer models to see if they can get some of this specialty care at a more reasonable cost. And so, yeah, so this is our investor deck. So, so really, you know, it's our top of the funnel is, you know, getting people into the door. And then what we're providing to our pharmaceutical clients is that we're showing them, we can get them to the door, we can get them seen by a doctor, and then we can convert them into patients. So these patients are coming in, and it's all shared decision making. So, you know, the patient is coming in interested in finding out if they're candidates for sublingual immunotherapy. Once we find out that they're interested in it, then we do the necessary steps, which is getting them tested for allergies. And that's the exciting part about all of this, is that we have actually just launched our own an at-home allergy test kit, which is also CLIA certified and can be reimbursed by insurance. Right now we're doing HSA, FSA payments for the at-home testing, but we will soon start billing insurance for those at-home test kits so that we don't have to take payment from the patient. So, you know, I heard previously on some of the other presentation, what's the difference between HIMSS and Roe? Well, at Cleared, we're really just focused on that allergic patient. So we're really just trying to be that platform that's working with only board certified allergists. So a lot of the other companies, which, you know, are great, but they use nurse practitioners, they use family medicine doctors to prescribe specialty medications that really do require a specialist to understand how to care for a patient appropriately. And so, you know, one of the things that we're also doing is being a sustainable company and working for the planet because of the link between allergies and the environment. So, you know, I think the way that we set ourselves apart is essentially just our partnerships that we're forging with pharmaceutical clients. Yeah, and our next pharmaceutical client is on deck for asthma treatment, biologic treatments. And so each relationship is going to look different. You know, that one is probably going to be more of a screening tool that we're going to provide. Yeah, and so if anybody has any questions, I'm happy to answer. And I also would like to thank Charm, because we've used their back end and are, you know, kind of integrating with their API with our asynchronous consults and the questionnaires, and also with some pharmacy and even swipe, like we're doing things with payment methods, and Charm has been able to integrate some of that stuff too.
Thanks, Payal. This is a great presentation. This is Yuli Cheripalli. One question. Is your business model going to be selling pharma medications that are more expensive versus your branded generic medicines? And won't there be a conflict between the two?
Yeah, so it's not really, we're not directly selling, right? So when a pharmaceutical client is working with us, we don't own those medications. We're not selling them on our platform. We're the prescribing physicians. And so meaning we're kind of the platform that sets the stage for the patient to come in, answer the correct questions, and then it goes to an independent group of physicians that are familiar with the medication. And then we handhold the patient to getting tested, to figuring out if they're a candidate for that. Where we are using our own medications is more on the over-the-counter medications for allergies, for example, that you still have to use in conjunction with some of these pharmaceutical prescription therapies. And then there's also some prescription therapies that we have that we are labeling with our cleared brand. So it's a combination of, someone's insurance is paying for it, but then also, for example, with this ALK partnership, now that we're seeing that so many of our patients that are coming on our platform have either lost insurance or don't have insurance, and this is kind of how they're seeking out their healthcare. We're working with ALK to provide a cash pay price for the sublingual immunotherapy tablets. And with our at-home test kit, we don't have to worry about the patient not having insurance. They can pay out of pocket and it's reasonable. Now, if you were to go to a regular lab to get blood work done for your allergies, you would definitely pay $1,000. And our test is, $150 to $200. $150 right now because we're having a deal, but $200 normally. So it might sound kind of confusing, but the pharmaceutical partnership is mostly, I would say, for awareness and for screening and for seeing if a patient is viable for a treatment.
Thank you.
And here, I don't know if I missed this part. Are you employing the physicians that are doing this, or are you creating this referral network where other people, they pay a monthly to get referrals from you and then have access to this service?
So this is all through telemedicine, and we're using a independent group of physicians, an MD integration. So they are helping us. They recruit the doctors, they make sure that everyone's licensed where they need to be licensed. And then once a consult comes through, it goes into their platform. And it's, like I said, we're not doing so legally. You can never, provide the service and then also kind of sell.
It's the stark law type of things. Yeah, it
would be a conflict of interest. So the physicians are independently contracted, but they understand, they're familiar with the medications that people are interested in seeing if they qualify for them. So that's a huge difference, because for this company, for example, for ALK, they've had a huge issue with doctors just not understanding their tablets and not wanting to prescribe for a number of reasons. Number one, allergy shots actually bring in more income for a doctor than prescribing sublingual immunotherapy tablets, which go through your insurance. A doctor doesn't get reimbursed for that. And so the pharmaceutical company is just having a hard time for the right patient who doesn't want to get allergy shots, getting an allergist to understand that there are patients that may not be the allergy shot patients, but would be perfect for the tablet.
Okay.
Mm-hmm.
This is Dr. Dickerson. How are these patients screened? In our area, you could anaphylax with the wrong dose of a sublingual even. Do you pre-screen with the testing? How do you all go about that?
So, with sublingual immunotherapy, the biggest thing is that if they have asthma, for example, their asthma needs to be under control. And so we screen for any kind of breathing issues. We screen for any, signs of, for example, eosinophilic esophagitis, which can also be a contraindication for sublingual immunotherapy tablets. So anything that could be a contraindication, we're screening for that. And then the first dose of the sublingual immunotherapy tablets. So these are the FDA-approved sublingual immunotherapy tablets, they're called Odactra, Ragotec, Grasstec, they come in one dose, and that's the dose that you take daily. So you're not, it's not dosed based on person, it's just a strict, like it's a straight dose that every patient gets. And the rate of reaction is much lower for these tablets than it is for allergy shots. And so the first dose of immunotherapy is always, it should be under physician supervision, and they're always given an epinephrine device too. So the way that that works is the patient has the option of going to their primary care doctor, and then we send a whole packet to the primary care doctor, much like we would if someone was needed to get, like, for example, I have patients that are college students that want to get their allergy shots at their college nursing facility. And so we send this packet to the nursing facility with, this is how we want the patient to take the medication. These are the factors that you have to watch out for, et cetera, et cetera. So that is what we're doing with the first dose of immunotherapy for the patients that do qualify.
All right. Thank you for the great presentation, Dr. Gupta. So we're going to be going to a 10-minute break. So if anyone would like to stretch their arms and legs, Vivek will be doing yoga during this session. You can join him and enjoy your time.
Namaste. So we are mostly now starting with some breathing practice, pranayam. So pranayam is the Sanskrit word for breathing practice.